Luân from Vietnam. Everybody know him. Yeah. He is the vice president of BSIR. He will talk about territorial again. Luân, please.
Thank you so much. I think that my topic is not relevant to the first three topics, and I think that the first three topics is very wonderful, with very done by very talented officer like Officer Wong, Officer Ho, and Officer Gino. My topic just related to one of typical and not likely interventional radiologists want to do, because there's some complicated, complex scenario, and they don't want to treat the patient because most of the patients having not good results. But for me, treating with electrobacterial venous confirmation is very exciting for me. I would like to show you how it can do and how it can work with the patient. And nowadays, in my hospital, I receive a lot of patients from all over Vietnam come over, and I can help them out with their problem. So, first of all, as we know, AVM is not popular. It's not popular in the world. So we know it's in the central nervous system rather than the peripheral areas. And management and Q is still debated. There's some central and there's some professor like Professor Go from Korea and today became very well with aliens. But in the other center, they don't have the same results like that. So that is why it's still debated how we can do that, how we can treat the patient with the aliens. I think that everybody agree that endovascular treatment is very like a first line, and there is a second treating for patient, and also it's a first choice in the case we the shower for patient. And the target of the endovascular management of the AVM is we have to close the nidus. We have to embolize the nidus and also fistula. That's a key point. And we have to perform that very well, following that anyway we want to perform. And I think that the classification of the AVM is very important. That makes us, help us to make a plan fit for the AVMs. There are some kinds of some kinds of alien classification, but for me, a good classification have to be very simple, applicable, and useful for treatment. And there are some kinds like clinical classification that's stronger than as you know, and in the angiography classification, we might have like a Jordan classification and Yates classification. And this is the Jordan classification. On the right side, you can see that's the reverse classification, and then Professor Dole is update about the classification. There are three kinds of classification. The first is multiple shunting from the anterior to the venous size. And the type 2, that's a little bit complicated with two subtypes, type 2A, type 2B, and type 2C. And also there are type 3, the micro shunt from anterior to the inner. And also, there are two more subtypes, type 3A and type 3B. These are very, like popular in the Asian countries like Korea and Japan. For Yale classification, Yale goes both on their my master, so I studied all for both. But for Yale, he's classified for ATMs becoming like 4 times. The type 1, that's direct fistula between the airway and vein. It's normally seen in the pulmonary anterior fistula, and also for direct, like in CNS, like CC fistula, for example. And the type 2, that's multiple shunting in so-called the 2 nidus, that's the type 2. And type 3A and type 3B, that's different about running vein with a single running vein or multiple running vein. And in type 3A and type 3B, the reason truly is on the venous wall. So that's a very important thing. And type 4 is similar like type 3 in the classification. That's a multiple micro shunting between anterior to the ventral shunting. So in daily practice, I'm using Yates classification, but I just make it short for me to memorize easily. And I think that because it is sample, like applicable, and it's full kinds of angio architecture. Because anterior venous malformation is very important that you have to understand about the angio architecture of the nidus. So I use the Yale classification because they have full kind of angio architecture. And it's made me very helpful to make a plan to treat for patient. So this is my short Yale classification group. Type 1, that's sun or sun fistula. It can be approached through the transseptal or transvenous one or direct contour to treat for this patient, this kind of shunt. Type 2 doesn't mean the 2 nidus. It's normally seen it's usually seen in the CNS AVMs, but we can sometimes see it in the peripheral AVMs. In the type 2 nidus, we can use normally use direct contours, transseptal or transvenous size 1. And type 3 does mean you're gonna have a lot of shunt on the venous wall. It's gonna be, make the patient having, like a big or large venous drainage and multiple shunting from the arrow located close to the veins. And in this kind of, in type 3, we can use multiple kinds of treatment by direct contour with or without compression. I'm gonna show you that. And or we can approach to the transvenous one. And type 4 is very, very complicated type right now. And because it's very multiple microshunt, so that one, we cannot do approach through the transseptal one. So that's why next time I approach through this one by direct contour, or sometimes transseptal approaching. So I want to just show you a couple cases. For example, this case, the patient comes with, you think that this is like, like a nidus, but it's only one shunt here. Only one shunt here. To go directly to the venous one. And the 2 nidus, that means you can see there's multiple shunting inside this. And we cannot determine whether to shunt or not, but we think that that's a 2 nidus with multiple shunting inside. Type 3 does mean you're gonna have a big draining bench, and then multiple arteries go shunting on that venous wall. And to be go that we can direct contour through the venous part. And when we check contrast media, we can see multiple shunt from artery to the venous side. And the last one is multiple microshunt. And you can see that multiple microshunt, from the ulnar and radial artery. This very small artery is, making the shunt between anterior and that's one. So how do we manage the ABMs according to subject classification? So in my process, I really love to use Atulango. I did it because that's the strongest and very good to queue for the region, and I use it very regularly. Sometimes I use coils and glue to reduce the space inside the Venus range, or some kinds of the tunitis. And we might following the ABM position, we sometimes use compression. We use a manual compression. We don't use a tourniquet because tourniquet we cannot control it. But if you use the compression with your hand, manual compression, it can be easily to determine how hard we can apply for the drainage or how hard we can apply for the airway as well. So, but most important thing to treat for the ABM, we have to have integrated angel architecture of the ABM. That's very, very important. And we, with understanding of angel architecture, we can choose the good way to approach the nidus or the fistula. And again, in some complicated cases, after first or second treatment, the types of the classification of the ABM might change, and we might have a other strategy. So I would like to show you a couple example. The first is Taiwan again. The patient comes to the hospital because the palm of her front, and this is a CT scan. You can see on CT scan, a lot of people think that this is like the tunitis or type T2 or T3 sample. But to answer that one, we have to carefully integrate it. And in this case, you can see clearly that's only one single airway. It's the kinking and tortuous airway from the superficial airway, supply for only single fistula. And after that, that's a dilated the venous pouch. It's make the patient look like type 2 or type 3, but it's really true type 1. Okay, how we can do it? That we can approach the fistula by using microcatheter to go through. But you see, that's a kinking, and sometimes you can hardly to advance microcatheter. Even you can use like a smaller one, microcatheter. But for me, I'm easily to direct puncture, and I direct puncture the needle with the needle tips tend towards to the fistula, like this. Like this. I put the tip of the needle is tend towards the fistula, and then I will inject the ankle on within compression of the venous range. And within 5 ml of ankle alcohol, it looks like imposed on the wall of the venous pouch. And after that, we perform the angiography. It's totally gone. Is make the flow to the fistula is very slow, and I think that now is good. The patient is good, and a month later, with the CT scan without any reason, that's a good result, and she's very happy with the treatment. Actually, the patient with a very cheap cost, very cheap, only 5 ml of the alcohol. The patient is very happy. And we don't need to, pay a lot of money for the microcatheter or glue or some kind of onyx to solve this problem. But for me, I prefer this way. Okay, the type 2, I don't want to repeat it. This patient with, necrosis at her lung, and it makes her very upset about this reason. And the patient having CT scan, you can see. The patient have a resistance middle sacral artery supply for all AVMs. How can we classify this lesion following for Dole classification? No, this is a truly type 2 according to TS classification. Because of that, you can see this is a truly neither supplied by middle sacral artery. Okay, this is very complicated because not only for middle artery, but also for the internal urinary artery supply for the AVM as well. Both sides, the left side and the right side, you can see. So to treat the patient is very complicated, and we have to go a long way. The first, I walk the way through transarterial one, go to the median sacral artery. And I try to go deeper in here. But unfortunately, I cannot go to the farther part. So I cannot inject arterial hormone because at this tip, inject arterial hormones may destroy everything for like normal practice. So in this place, I just inject for 50-50 arterial hormone and then inject some fluids. After that, I do direct puncture. Direct puncture you can approach easily for the nidus right here. You can see that very clearly the nidus. Multiple shunting inside. And with this approach, I can easily inject arterial hormone. And with 12 mil of arterial hormone, I can easily solve with that nidus. And for this patient, I did 7 times. So the result is quite good. The reason is, stricken slowly, but she need about like 7 times of the treatment and totally solve for the problem. And this is the first imaging when she comes to the hospital after 6 times, and this is after 7 times. The reason is totally gone, and everything is solved. The patient is still, follow up until right now, And type 3 again. Type 3 is that's truly the shunting between the artery go to the venous wall. This patient comes to the hospital because of swollen knee on the right side, and on the MRI you can easily to make a diagnosis with the peripheral AVMs on the knee, on the right knee, and we will form angiogram. You can see that's multiple artery will supply for this area. You can see this is a very early stage, and later on you can see this random veins, okay, and multiple shunting on this. Again, with this patient, there's a lot of doctor do choose the transarterial one because it's easy to approach. But look at on the very kinky and tortuous area. Sometimes we can reach it and sometimes we cannot. So, but for me, I prefer choosing direct puncture because it's very easily to direct puncture under at that position. I do direct puncture. You see, when I direct puncture at the venous side, very close to the shunt, and then when I inject it, I use my hand to compress, manual compress like this. And you can see that's the contrast media will go directly to the shunt. So that might be very easy to inject absolute alcohol with a manual compression. And I performed about 8 mil of absolute alcohol, and the results look very well. It looks like two balls holding up the shunt, and the patient come later on is the AVMs are almost 2 balls in size. So we done with control angiogram 3 months later, the AVM almost done. So it's very good result, So the other patients again with the ADMs. And you can see easily ADMs. And then with direct puncture, you can see the multiple shunting from the airway. And then we check about like 15 ml of absolute alcohol, and it's gone. And the patient might control angiogram to right now is having no significant recurrent ADMs. So TEF4 is very difficult for treatment, but sometimes we luckily having good results. For example, like this patient having multiple shunting, and we use direct puncture to approach for as much as possible for micro shunting, and then we check absolute alcohol, and we do the 3 ml of absolute alcohol, and we solve that up. This is the first when a patient comes to my hospital, and this is 2 years later. Most of the symptoms gone, and everything is still intact. And this is the angiography when we perform 3 years later. It's almost gone. I think that's a very good result. So how to plan a treatment? It depends on how to analyze the set of the ADMs. I would like to show you this case because this case is a very difficult case as well. So the patient comes to the hospital because of a toe on her his elbow. Patient like 20 years old, and on the angiogram you can see this is the solar aneurysm close to the brachial airway, and also some small branch from profound and also radial branches of the brachial airway supply for ADMs. That's the ADM around here, and this is the solar aneurysm. So everybody agreed to me that this patient should be treated right, but how many doctors in this room use the coil to treat for the solar aneurysm? I think a lot of doctors we think that using coil to treat that. But this is true. This is the solar aneurysm. Solar aneurysm is not easy to treat with the coil. So I use following my way. I use direct puncture. You see, and use balloon go through from the radial airway, and use balloon to block the way from the solar aneurysm go to the airway, and then I inject absolute alcohol. How much absolute alcohol I inject? Only 5 ml absolute alcohol. It's gone. This is how it looks like, and it's gone. When we release the balloon, it's gone. And the remaining of the ADM is still resolved as well. After that, you can see I use direct puncture for the other with my manual compression. I can control that well with the alcohol injection. That's very well. And the patient, lost my follow-up, but he's came back again for reevaluate, and the remaining of ADM is still there. And you can see that's very complicated case. And you can see you can approach through the brachial this brain, go to this way, but you cannot go up farther for ADM. So if you use this way, you cannot totally cure this ADMs. I choose for my way, direct puncture again, and I have to choose which one is a good place, good position to inject absolute alcohol. And I go from that within the 12 ml of absolute alcohol, and you can see it's gone. Control angiogram is gone as well. So it's a wonderful result. Another case is the hospital ADMs, masturbation having multiple time with bleeding, scalp bleeding, and masturbation is very, very upset. And on the MRI, you can see ADMs on the scalp, hospital scalp. This is very wonderful. You can see this is a CT scan having some abnormal vessel around here. It's big. It's not airway, but it's a vein, but running veins from APMs down to the circulating vein. You can see this one. It's very, very complicated. And I performed the angiography. You can see that supplied by multiple, the bilateral is an hospital airway. You know, go through this line and supply for this area. And this one on the right side, you can see that's a true airway supply for the agents. And what kinds of type of this vision? Following the information I just gave. And I think that this patient having like type 3, according to the because I have some, vein that's an abnormal vein. So we had to target for abnormal vein. And I use direct puncture. At that moment, I don't want to use a microcatheter anymore and use direct puncture. I approach to the vein, the abnormal vein on the scalp, and I inject absolute alcohol. It's about like 3 mil, and you can see really 3 mil. You can see, you can see some thrombosis. You can see some thrombosis, but not totally thrombose of the veins. So we need, many multiple or more sessions to treat it. And this patient I spent about like 6 sessions and successfully cured the issue. She came back to the hospital for the evaluate, evaluate, and everything's done successfully after 6 times of the treatment home. And now she's totally normal, no more like bleeding on the scalp anymore. So in summarize, I think that your shortened yes classification is very important for us and help us for making a plan for treatment of the aliens. I think that the shortened yes classification is very simple, applicable, and it's sort of that the full kinds of aliens can try to detect. And we can support the transector, transmitter, or direct puncture approaching. And I think that two aliens probably be seen in our data. And sometimes we need to combine with surgical removal or like aesthetic surgery for having the patient out. And thank you very much.
Okay.